Hello everyone, I would like to welcome you in a presentation of ketamine versus rTMS. I am Dr. George Mikellides. I am a consultant psychiatrist and a clinical assistant professor in psychiatry at the University of Nicosia. Depression is a common mental disorder that affects more than 264 million people around the world. Effective treatments and first-line treatments include pharmacotherapy and psychotherapy. However, there is around 30% of patients that do not respond to antidepressant medications and are suffering from the so-called treatment-resistant depression. Treatment-resistant depression is diagnosed when a patient is not experiencing any significant clinical improvement from at least two types of antidepressants. So we will talk about ketamine and repetitive transcranial magnetic stimulation. We need to be aware that patients are in need for new non-pharmacological treatments, alternatives in regards to treatment-resistant depression. Let's talk about ketamine. Ketamine is a systemic mixture of two enantiomers, S-ketamine and R-ketamine. Ketamine works as an N-methyl D-aspartate receptor antagonist and is associated with rapid and robust antidepressant effects in treatment-resistant depression patients. The administration of ketamine was also found to be effective in bipolar disorder as well as in suicidal ideation. Especially, repeated administration of ketamine may be associated with rapid and long-term sustained antidepressant effects. It induces a process of the so-called metaplasticity through the postsynaptic functional changes. This may explain why repeated intake of ketamine dose produces a sustained effect. As a drug with brief euphoric effects, which may last from 1 to 2 hours, ketamine must be administered under controlled settings. Some of the side effects of ketamine include dizziness, drowsiness, poor coordination, blurred vision, feeling strange, lightheadedness, headache, and nausea. Ketamine can be given in different ways, such as IV, IM, oral, sublingual, subcutaneous routes. Only very few studies are available in terms of the use of IM ketamine, so in our study we have used IM ketamine. A recent study aimed to compare the two, IM and IV, in treatment depression, showing that a small dose of IM ketamine, even 0.25 milligrams per kilogram, is as effective and safe as a larger dose of 0.5 milligram per kilogram, and there was no statistically significant differences between IM and IV groups. We need to be aware that IM ketamine has a 93% bioavailability. Let's talk about rTMS. It's a non-invasive brain stimulation method using repetitive administration of electromagnetic pulses to target regions in the brain and modulate neural activity. It has been shown that rTMS lead to longer-lasting neuroplastic changes with beneficial clinical effects across a variety of neuropsychiatric disorders. rTMS is by now an FDA-approved treatment for obsessive-compulsive disorder as well as treatment-resistant depression. In most people, low-frequency rTMS is considered as less or 1 Hz. This decreases the cortical excitability and be inhibitory on the other hand. However, if we consider higher frequencies, more than 5 Hz, it has been shown to increase cortical excitability and be excitatory in its fashion. Dorsolateral prefrontal cortex is the most prominent and commonly used targeted area in rTMS. It has been shown that the use of rTMS for several weeks on this region, it can be safe and effective treatment for treatment-resistant depression. In addition to the standard high-frequency 10 Hz protocol, 3000 pulses, a theta burst stimulation has more recently gained in popularity due to its much shorter treatment duration, which is only for 3 minutes. In 2018, FDA cleared the intermittent theta burst stimulation protocol for major depression disorder in adult patients who have failed to receive satisfactory improvement from prior antidepressant medication. Ketamine versus rTMS. Only a few cases and a long-term retrospective review reported that the combination of ketamine and rTMS may be effective long-term therapy for patients with depression. There is no study comparing the effectiveness of ketamine and rTMS in patients with depression in a naturalistic setting. So more research is needed in this area. We have done a study which has been published in Frontiers in Psychiatry this year, a retrospective naturalistic study comparing the efficacy of ketamine and repetitive transcranial magnetic stimulation for treatment-resistant depression. The aim of this study was to describe and compare the acute antidepressive efficacy of both IEM ketamine and rTMS in depression. 12 patients received IM ketamine treatment, 8 sessions twice weekly over a period of 4 weeks. 12 patients received rTMS treatment, 30 ITBS treatment sessions over a period of 6 weeks. Inclusion criteria was patients' clinical records in the study, age 18 and above, patients meeting the criteria for either moderate depressive episode or a severe depressive episode without psychotic symptoms, patients not experiencing any clinical improvement from at least 2 different methods of antidepressants, and 4, the existence of completed clinical evaluation prior and post-treatment. Exclusion criteria were patients aged than 18 years, mental objects or implants in the brain, skull, or near head pacemakers, mental plates. Hamilton Depression Rating Scale was used, Hamilton Anxiety Rating Scale, Beck Depression Inventory. The patients had chosen the treatment method based on their preference, hence they were not randomly placed to these 2 experimental groups. Depression and anxiety severity were measured prior and after completion of each treatment using clinical rated and self-rated assessments. The results shown that analysis did not differ in any demographic, age, gender, as well as clinical duration or current episode number of episodes during the depression, number of unsuccessful antidepressants tried in current characteristics. We will see the graphs here and we will also see the results in the table. Here we can see the demographic characteristics of our patients in the ketamine group, in the rTMS group, also the duration of depression, duration of the current episode, number of episodes, and the rating scales. Post-HDRS, Hamilton Anxiety, Beck Depression scores were significantly reduced compared to baseline scores in both groups. Responders were classified as patients with 50% or greater decrease from the baseline scores to the post-treatment scores. Remitters patients with HDRS post-score less than or equal to 7 for Hamilton's, and Beck Depression less or equal to 13. No significant differences were observed between the TRD patients of ketamine and rTMS group in treatment-resistant patients. We can see the differences here in between responders and remitters. Results were consistent in all 3 clinical assessments. The interaction effect between time and experimental groups was not statistically significant. The effect of experimental groups was not statistically significant. There was a statistically significant main effect of time, suggesting a difference in the pre-treatment compared to post-treatment. Here we can see the bar graphs. We can see very good results in both groups in reducing the HDRS, the Hamilton, and the Beck Depression Inventory. Conclusions. To the best of our knowledge, the comparative study was the first that directly compared the efficacy of these 2 treatments. We've seen significant pre to post treatment results. Further results show that high remission and response rates in both groups with no statistical difference between the patients of ketamine group. No significant side effects were reported from either the rTMS group or the ketamine group. Results show the ITBS protocol has received FDA approval for moderate depression and is equally effective with IM ketamine, which is not an FDA-approved treatment for treatment-resistant depression. IM ketamine therapy has the potential to reach similar effects. Thus, further research with more focus on the use of IM ketamine treatment in depression is therefore suggested. It's good to highlight that there is a systematic review and meta-analysis in 2021 which compares IV ketamine to S-ketamine, the nasal spray, and this has shown that IV ketamine is more effective than the S-ketamine spray. This is a retrospective design study, no prior randomization. I'm discussing about the study limitations, very limited number of patients, sample selection bias, only patients who completed the total number of sessions required, and patients with completed clinical evaluations prior and post-treatment were included in this analysis. Future research should further develop and confirm these initial findings. Clinical assessments should be collected weekly in order to investigate whether there are differences in responses, and a follow-up measurement is needed to examine and compare the long-term efficacy of these treatments. Thank you for listening, and I hope that you enjoyed our presentation on rTMS and ketamine. If you would like to get in contact with us, our website is www.cyprusrtms.com. Thank you for listening.